Hello, my name's Edward Farrant. I'm an optometrist working in Taunton in Somerset in the UK. I co-own the practice with my wife Sarah, and we're keen on specialist clinics like dry eye and glaucoma and myopia management, and we've been practicing now for about 10, well, it's more like 15 years. So the clinical aspects of the diagnosis of myopia are changing rapidly now that we have become more familiar with myopia control as an option. So traditionally, patients would come in with their anxious parents because they'd been struggling looking at the board, and that was the first time that they perhaps would have been visiting for a sight test, around the age of 7 to 11 perhaps. And duly, most of us would be issuing them with glasses and then monitoring them every 6 to 12 months, watching that myopia progress over time. The really exciting thing now with myopia control is that we have a possible intervention to try and reduce that depressing sight of seeing the patients yet again be told that their eyes are getting worse each visit. And it's really exciting to be able to now intervene and try and stop that from happening. The importance of axial length in myopia management is becoming more and more key to our understanding of myopia control. So we know now that patients at around the age of 6 to 7 with a low hyperopic prescription of around 0.75 will have an increased chance of developing myopia, coupled with the fact that they may have a family history of myopia, and indeed if we see a change in their hypermetropia shifting and reducing over a year, will by half a diopter we'd know that would increase their chances of developing myopia. Axial length measurements in normal populations are between 23 to 25 millimeters, and anyone over 26 millimeters will have an increased chance of myopic pathology later on in life. Traditionally, you could argue that people would say that their refraction data would give you all the information you needed to know that someone was at risk if they had a high prescription. But the key thing with this is that we now know that we can potentially intervene to try and reduce their prescription. And the key thing about axial length is that we have a buffer of about 18 months. So if we know their axial length is increasing over an 18-month period, that can predict their myopia development, and it can start to predict how much myopia they may go on to get, depending on how rapidly the axial length is changing. And I think this is a really key, important message, and the reason why we should be measuring axial length in our patients now. The importance of child and parent education is now becoming ever more important, because traditionally all we were able to do was issue either glasses or contact lenses to these patients, and at that point in time we didn't know that we could actually influence the outcome of their final prescription. If we are not having that conversation with patients and at least offering them the chance to try and reduce their myopia, then you could argue that would be negligent behaviour. It's effectively not giving them full information, and so it would be key to the importance of explaining that these options are out there. And even if you're not practicing myopia control, patients should be made aware of it. The role of MYAH in myopia management is that we're now able to take quick, easy measurements of axial length and topographical data using a simple machine which is friendly for the patients and friendly for the practitioners. And we'll be able to build up data using an easy to read graph, which we can share with the patients and their parents over time, which I think is quite exciting to be able to educate them on what we're now able to do for those patients.